My name is Dr. Stanley Szefler, Deputy Editor for the Journal of Allergy and Clinical Immunology, and I'm here with Dr. Alain Michils, and we're here to discuss his paper entitled Exhale Nitric Oxide, a biomarker integrating both lung function and airway inflammation. A very interesting paper that's will be published in the journal. And I'll ask Dr. Michils if he could just summarize the paper.
Yeah, exhaled nitric oxide is usually recognized as a marker of airway inflammation, but other determinants can be very important, and we thought that lung function can be quite important, as it has been shown that the reduction of FEV1 induced by bronchoconstriction experiment reduce exhaled nitric oxide. So we took the opportunity of this model, the allergen challenge, to create both a change in airway calibre and a change in airway inflammatory process to see how they conjunct together to change exhaled nitric oxide. And we were quite interested to find that, as we were expected, the reduction of FEV1 without a change in inflammatory status reduced exhaled nitric oxide, but as long as the late reaction progress with an increase in the inflammatory process, then exhaled nitric oxide is influenced by both processes, returning just to normal, like before the challenge, where there was no inflammation, while at age odds, during the late phase reaction, there is an important inflammatory process. So we concluded that if one wants to use exhaled nitric oxide in the clinical setting, because asthma patients do have change in airway calibre and airway inflammatory process together, you should take into account the change in the airway calibre to evaluate exhaled nitric oxide as monitoring of airway inflammation.
Very good. And after your late phase response, you saw an increase in exhaled nitric oxide. Is that
Yes,
correct?
we saw a progressive increase in exhaled nitric oxide, returning first to normal, while the inflammatory process is quite big already, and then progressively, as the lung function returns to normal, the exhaled nitric oxide increases much more, of course.
Very good. And what do you think your key messages are for clinicians who now use exhaled nitric oxide in their practice?
Well, we were all quite disappointed about the use of exhaled nitric oxide to guide anti-inflammatory therapy in asthma. There are quite a lot of studies that showed that it was not so useful in improving. But one of the problems with these studies that were quite well designed is that they did not take into account the change in FEV1 that occurs similarly. And I think if we want to use it in the future, we should find a way. I don't have the answer so far, but we should find a way to integrate both the change in lung function with the change in inflammatory process.
One of the things that I observed as I was reading your paper and thought about it is that we often think that exhaled nitric oxide will go up in the allergy season for patients that are sensitized. So would you think that the values might be falsely low due to bronchoconstriction during those seasons? In other words, is it a kind of a chronic effect or just an acute effect that you're observing?
That's a very interesting question that we try to investigate it right now in the birch and grass pollen season in Europe right now. But it might be that some increased inflammatory process occurs without a change in constriction, FEV1 change, in the lung of patients suffering from rhinitis or even rhinitis and bronchial hyperresponsiveness, and that might be one of the answers. We are trying now to identify what are the sources of exhaled nitric oxide in terms of location within the airways of this increase of exhaled nitric oxide during the pollen season in even non-asthmatic patients.
Well, thank you very much for summarizing your paper and providing some clinical insights. And again, this paper will appear in the Journal of Allergy and Clinical Immunology, and we thank Dr. Michils for discussing the paper with us.
Thank you very much.